very well versed with this thing. So once you go into the center of the central fossa, you'll get a dip. So that dip is of your pulp chamber. Now you still go down. Now you're drilling onto your dentine and then your cementum. After your cementum, you'll get a slight resistance in pressure. Now that's your bone. Now I know it's extremely difficult, and that drop is not as drastic or as significant or as conspicuous as your first drop. But yes, once you are getting into the dentine, and if you get a less of resistance, okay, please be assured that you are into the furcation area and you need to stop over there, because you don't need to go down more deeper. Why do you don't need to go down more deeper? Is because I need this interradicular bone if I'm contemplating placing an immediate implant, because my immediate implant is going to come into this interradicular bone, and I want an interradicular bone. I don't want my burr to destroy that. So once you get a second drop, please stop. Okay, the burrs which I use are called as this zirconia burrs. They are excellent burrs, right? So they come in this 28 millimeter length, and they are aerotor burrs. From here you can see that. So I don't prefer the 22 millimeter, but I definitely prefer the 28 millimeter zirconia burrs, which are longer, they have a better reach, they don't fracture. I had my share of using all these burrs. Okay, the first one is from one company in Gujarat. This is an excellent burr. Okay, this is what is a socket shield burr. Okay, this is from Comet. This burr is from Comet. I'm extremely happy with this burr, no doubt about it. The only one thing which I'm not comfortable is that it's too long. Okay, it's too long. But it's an extremely effective burr if you are into implantology, and I would recommend if you can buy this burr. Right, the rest of the Chinese ones also I've tried, but I'm absolutely not in favor of that. In fact, these burr, which I don't know where they died from, got very lured because it was cheaper. They claimed it was carbide. It was not carbide. Okay, and then it did not cut the tooth. As far as this is concerned, they claimed that it was carbide. My burr tip got fractured inside the socket, and I spent more amount of time searching for this burr tip rather than placing an implant. So I'm extremely scared with this. So as far as burrs, if you want to buy and into implantology, kindly buy this from Comet or buy this from Trihawk. Right, now once you get this second drop technique, what you need to do is go buccally as well as lingually. So you get a buccal as well as lingually to totally split the tooth into two pieces as far as mandible is concerned. You come to maxilla later on. So you go buccally, split it, you go lingually, you split it. The next thing what you do is that you place your straight elevator between the two teeth and you just slightly rotate. It is at this time you will hear a slight cracking sound. Now in any other tooth extraction, that cracking sound sends chills down your spine, because you know that now you've fractured something and you're going to spend another half an hour to 1 hour just retrieving that. But in this case, you do require that cracking sound. So it just reinforces that you have split the tooth into two pieces. If you're not too sure that whether you have gone to the base or not, I would recommend, if you're doing it for the first 5-10 times, okay, might as well take an IOPA and confirm that whether you've gone to the base of it. Okay, it's always better to be slightly short of the furcation than you go beyond the furcation. So if you are a bit doubt about the second drop technique, about second drop, I would recommend you that take an IOP at this stage and then just go calculate it on an RBG as to how many millimeters you are to from the furcation, and then go about doing it. But rather than don't overdo it. Right, now once you have split the tooth into two pieces, okay, you use a straight elevator. You'll be surprised as to how easily this tooth gets removed. Okay, you straight your elevator, you shift it mesially. Okay, use your straight elevator distally, and you extract the distal portion of it. Okay, it will follow the path of least resistance and it will come out extremely easily. Now, presently what I use periodontums. I don't use the 90-degree periodontums, but I start with straight periodontums. So my periodontums go straight down inside. Okay, I slightly rotate it. I go around, cut. Believe me, this requires a lot of patience. Okay, but implantology is all about patience. What takes time takes time. That's the rule of surgery and implantology. So go inside, slightly elevate it. Go inside, slightly elevate. Go inside, slightly elevate. Expand the periodontal ligament space. Cut the periodontal ligament. Okay, use the viscoelastic property of your bone. Expand the socket, and then take the tooth out. Okay. Now, once the tooth is moving in the socket, you can just pluck it out most of the times. Now, if you have a root piece which is slightly there, you might just try. There are a few things which I have tried. Okay, use your buccal cortical plate as a fulcrum, and you can take this out also. It's difficult. It's very easy, which is seen over here, but to do this, it's a bit difficult, and many times you can chip out this buccal cortical plate. But yes, it can be done. So if you have a tooth which is a bit moving, okay, you can try this out. Okay, so this is exactly what I was trying to tell you. So you have a root piece over here, your straight elevator, your peritoneo goes over here, and then it goes down and down and down, creates space, and then the root piece goes out. Now, what about sockets? What about root pieces? Now, you might use your files and your H files and your key files to get into the apex. Okay, if you have a root canal which is seen over there, but if you have a root canal which is not seen, or a calcified tooth, then it becomes a bit of a problem. People have used apex saws and so many things to get into that, or you might take a flap and then drill the bone. I would not recommend that. What I recommend is that you just take a slight, so small semilunar flap. Okay, just make a small burr hole over here and just pop it out, and this root piece comes out. Okay, but this by and large is an extremely non-invasive way. At the most, you end up having a small fenestration where you will take care of by doing bone grafting. Okay, over there. Okay, but at least the loss is very minimal, right? And if you do have a good amount of dexterity, and if you can observe this through the socket, then I might use this burr, okay, from Comet, and then I can actually go split the root into two, or I might just grind it off, right? So you may use it if you have a good amount of dexterity as far as indirect vision is concerned. Then you might use it for removing the root piece. If everything fails, okay, what you can do is just take a small semilunar incision, slightly drill a bit of a burr hole bit. I'm just not even telling you that you need to drill it. It's just a burr hole bit, and just push it out. It will pop out. This is one of the ways of removing the root pieces. Now you go in and suture it up. If you have not raised the flap, you might as well just place a figure of 8, and just close it up. Right. As far as maxillary extraction is concerned, slightly difficult. Like the conventional way, you raise the flap, okay, and expose the bone over here. I'm so sorry that these pictures are not very clear. Okay. Now in the maxillary extraction, it differs in a slight way. Is that because you have 3 roots over there, you need to do something like the sign of the Mercedes. Okay, Mercedes Benz. So they have the logo. So something like the logo that should be on the tooth, so that your palatal and the mesiobuccal and the distal buccal are removed separately. Now doing so, okay, then you go on to the weakest link. So the mesiobuccal root piece is the weakest. So you go inside, you remove the mesiobuccal, then you followed by the distal ones. Right. Now, one thing what I want you to observe is that as far as the palatal is concerned, the palatal will move buccally. Okay, so if you want to try to remove the palatal one, first make space by removing the mesiobuccal or the distobuccal ones. Once they are out, you have created space in the buccal, and the palatal, push it buccally, not palatally. So because the palatal root is somewhere like this, when you push it buccally, it comes out buccally very easily. So focus on the buccal aspect, push the palatal root buccally. Again, use of periodonts, this is what I presently do. When you're using the periodont, please be very careful so that you don't push it into the sinus. There is a very high chance that you might push into the sinus if the maxillary bone is extremely thin. Okay, so but be a bit cautious with that, and then you can just pluck it out individually. If you have raised the flap, close the flap. I am against raising of the flap, so no flaps for me. Okay, and this is how it should look once you have extracted it. Many times you are able to even place a nice good implant because you have maintained the socket and you have maintained the interradicular bone, and this is how actually your implant sits into an absolute extraction socket. As we go on in the latter part of the discussions, okay, I'll be actually demonstrating to you how to do how to place an immediate implant, and what are the things which you should look out in the socket before placing an immediate implant. But for the timing, because since this is the basic lecture, okay, the extraction and your implant goes in the center of the socket. Okay, so you have the interradicular bone and your implant sits in the center of the interradicular bone, and you have got nice good amount of good cover screw which are at the center, and they are not too buccally. As far as again the maxillary tooth is concerned, you might have resorptions, okay, of your maxillary sinus lining. So I want you to be very careful as far as splitting of your maxillary teeth is concerned, because you tend to have the sinus which dips into the furcation area, and this is exactly the place where you are going to section your crowns. So if you are not too sure in the first 5, 10, 20 cases till you have that dexterity, kindly I would advise you to take an IOPA with the burr inside the mouth. Okay, so with the burr you will exactly know where actually it is, or even if you're a bit scared that the burr is inside the mouth, you may even just take an X-ray to just observe where your otoractomy has taken place. Because all you know that your tooth is split, and so is your maxillary sinus floor. and when you're pushing the straight elevators or your periodomes, you're pushing actually the root piece into the sockets. Okay, so here we come on to the end of the lecture as to what are the other ways, non-invasive ways of extracting a tooth which usually would have gone for a surgical extraction. Okay, now in the next lecture I will be actually demonstrating to you how do we actually go about doing this extraction. So our next lecture, which is the lecture number 17, will be an actual video of a live surgery which I had recorded, and how to go about extracting it. So please do follow implantologic, the logic behind predictable implantology. This is Dr. Kerkar signing off. Thank you very much for watching.